Assume everyone is ready from our side of the table. Does the public want to speak on this issue? B. Those that would like to come forward, I have Shannon Smith Crawley. Would you like to come speak forward on B?
Thank you. Good morning still.
Good morning.
Shannon Smith Crowley, representing the American Congress of OBGYNs in California. And we've actually worked a lot on this behind the scenes. And I think that there is some progress that's being made. To your point about physicians being willing to work with the midwives, they already are at their peril. If they get busted, if this gets found that they're collaborating, they have no insurance coverage. Whether the relationship is collaboration, consultation, supervision, it's basically the carriers have said if you have anything to do with home birth, you will not be covered. Yet there still are working relationships. You can see in the outcomes reporting that there are a number of working relationships already in place. So one of the things that you've done over the last few years that's really going to make a difference in removing some barriers to the physicians working with the midwives is the outcomes reporting. Because the liability carriers, I've had some initial discussions, and they're saying, well, if there's a book of business and we can underwrite the risk, we know what the risks are, and they, believe me, they had all kinds of stereotypes. It's like, no. It's, you know, it's really, there is some good data out there. There are physicians working with these, with the midwives. Now that there is some outcomes data, they can look at underwriting the physicians. So regardless of how ultimately the relationship is defined in terms of the specifics of the supervision, we believe that the best outcomes for California mothers and the babies is for there to be a working relationship and to make sure that physicians are in the mix, that there's the consultation right now. Say, for instance, if you were a midwife and you had a patient and you had a question about whether she was still eligible for a home birth, or you just needed to send some, make sure everything was okay, it would be very scary to send her to a physician with whom you didn't have a relationship in terms of once she got to the doctor, what's the doctor going to say, and they're going to try and persuade them to have a hospital birth and not use the midwife anymore. So there could be some reluctance to really refer out to physicians when there should be. And then also the physicians that are working with the midwives now, they're kind of having to do a kind of, I know you're not having a home birth, but I'm not really knowing you're doing a home birth, and that's not really the best quality of care. So we think that the idea of having, we're at the point in time where I think we've got enough people that can really bring something to the table in terms of having an interested party meeting. We can have some liability carriers, and we also have a real asset that we haven't tapped yet, which is the state in the University of California self-funded or self-insured entity. And there are programs such as at UCSF that are specifically looking at workforce and the roles of different types of providers, that there are, I think, a lot of opportunities out there, and I'd be very happy to work with the medical board in identifying some of these interested parties, because we really think that not that it would solve everything, but the single biggest, hugest barrier is the liability coverage, and so we support the interested party.
So thank you very much for your presentation. I also have Julie Feldsmith D'Angelo speaking on this specific 21B1.
Julie D'Angelo Felmuth from the Center for Public Interest Law. I have a suggestion for a different approach. And I made this suggestion about 10 years ago, but it was probably before the Midwifery Advisory Committee existed. Your paper here says, although required by law, physician supervision is essentially unavailable to licensed midwives, as California physicians are generally prohibited in their insurance agreements from providing supervision of midwives who perform home births, lest they lose their hospital privilege and insurance coverage. If the insurance industry is refusing to cover an activity of physicians which is mandated by law, We have an insurance commissioner here in California, and I suggest that you approach the insurance commissioner, Dave Jones, and his staff. I suggest that you bring representatives of the Department of Insurance to your interested parties meeting. The insurance commissioner has the authority to hold hearings on this issue, the extent to which the insurance industry is refusing to cover this activity or refusing to cut off physicians who provide supervision. The hold hearings, make findings, and actually force the industry to cover this activity. If it's required by law, and I know it is, and it's been there on the books for 10, 15, 20 years, and we've never been able to crack this nut, bring the insurance commissioner into this conversation.
It's a very good idea. Thank you very much. Please identify yourself.
Sure. Ryan Spencer with the California Medical Association, and Shannon actually mentioned most of the comments, and we just want to officially support what she said. I mean, physician supervision is very important in terms of patient safety, particularly when there are medical complications. So if the board does decide to move forward with this action, the California Medical Association would like to be a part of the group. Thank you.
Thank you very much. Faith Gibson, would you like to come forward, please?
Faith Gibson, California, the Midway Advisory Council. I just wanted to provide a little background, which is that in the years before the passage of the LMPA, physicians were independently willing to provide backup arrangements for that every mother who was planning to have a home birth had some identified physician or an institution, such as a teaching hospital, that would provide care in the case of any kind of a labor that didn't progress appropriately, a medical problem, whatever the issue was. Once the LNPA was passed, which created, and there are the exist from ACOG and other places, that the creation of vicarious liability was actually the purpose of them having asked for that to be part of the law. The result of that, it did indeed create vicarious liability, or at least the assumption of it. The result is that the same doctors who would provide backup services or be willing to consult with us said they couldn't do that anymore now because their malpractice carriers wouldn't allow them to take on that relationship of vicarious liability. One of the questions that, one of the comments that frequently came up was that, well, if we as midwives had malpractice insurance, then that would make it different, that the reason that the malpractice carriers weren't willing to permit their I guess you call them customers, to do this was because they were the deep pocket. So I organized and administered for 3 years a malpractice consortium which covered not only licensed midwives in California but also nurse midwives and midwives in both New Mexico and Florida, all of whom provided community-based care. I did that for 3 years, and basically what we were told was, we kind of patted on the head and said, well, that's nice, but you know, any lawyer will tell you the only thing better than one deep pocket is two deep pockets. So it made no difference relative to the availability. That one of the changes that was made to the LMPA, an amendment to it in, I believe it was SB 1479 in the year 2000, was to remove some of the language in the original physician supervision provision and to replace it with a requirement that every midwife and every client that she provides care to have a document in the client's chart that identifies exactly where that client would get obstetrical care during the course of pregnancy if there was any question, problem, issue, the desire to have any kind of evaluation, a test or whatever, or to be evaluated for a complication, or if she needed, who would she transfer to if suddenly she developed high blood pressure or whatever. And then the same thing for during the labor and the birth, and emergency arrangements for if there were, in other words, an elective transfer during the labor or after the birth, either for mother or baby, and then what was our emergency arrangements. So that's already been going on. So I appreciate the concept, the conversation about the safety of the patient, but I do want you to hear that for 19 years, we have been doing exactly what I have described to you. We have not had supervision available. I live in Palo Alto, which is where Stanford Hospital is. You would think that would be the hotbed of access to avant-garde, care of whatever kind, including cooperative obstetricians. I have 0 people who are willing to be on the books. That what we actually do is a process often, I probably more than 50% of the people that I provide care to actually have concurrent care. And part of that is because they may have Kaiser, which is a little different kind of a situation. But they often, particularly for first-time mothers who have a fairly high transfer rate, not based on complications, but simply that the labor doesn't progress, that they decide that they want to have a pain medication, epidural, whatever, is that they are receiving concurrent care from an obstetrician. But even for that to occur, we have to do the don't ask, don't tell, which is that they don't tell their obstetrician that they're seeing a midwife. I just hate this. I used to be a labor and delivery room nurse. I remember the good old days when we were when obstetricians and me in my position as an L&D nurse were on the same side. We were a team. And now I don't know what to say, but, couldn't be worse.
Thank you, Faith.
I would like to address what Dr. Levine said. The way the regulation is proposed, that it says to provide emergency advice should complications develop. If a complication develops, we're transferring. I would like to personally see this say, and to provide emergency advice, or take out emergency. We're not talking about emergencies. To provide advice should risk factors develop.
Might I suggest that that's appropriate for the interested parties and
But
not now?
I'm trying to address what the issue.
They're not going to vote on they're not going to be, if they want to come to the interested parties, they'll come to interested parties, otherwise you'll be at the table.
Can the regulation be changed via the interested parties meeting?
Yes, oh, absolutely.
Okay. Then just to also, to Dr. Diego, that there are significant numbers of OBs in the state of California who would like to help us. That is absolutely true. I also know there are others who don't want to help us, but that is another story.
Thank you. Ms. Fairbairn, did you? I'm going to pass. Thank you. Appreciate that. So moving, any other public comment from people I haven't heard from? Thank you. I do have a motion to, yes.
Is it too late for me to make a comment here?
Oh, no, please make a comment.
This comment is colored greatly by personal experience with a total disaster with a midwife who had an informal relationship with a physician in my small town. And they were caring for a patient in a large town. However, when complications did arise, they transported the patient 60 miles.
Your microphone is not in front of you. They
large
can't.
town to the small town. The baby did badly, and everyone was sued except for the nurse, not even nurse, but the midwife. It's really colored my opinion, so I have to tell you that up front. But I'm extremely concerned because of the informal relationship. I believe there's a matter in front of the board currently as well regarding the supervision of people in plastic surgery centers who are doing Botox and things like that. And that's of great concern to the board, and I think this should be as well. I think
It is. You should know for years it has been very important to this board for many years.
The aspect is very troubling to me.
I'll be happy to have you read all of the previous, okay?
I don't know all that.
I will make sure you have the minutes, and you will see how important it has been and engaging it's been. Okay, so on the question of the motion, I have a motion to set a regulatory, where am I? For the workshop. So I apologize. So I have the motion. It's been made and second. All those in favor of the motion, please say aye.
Aye.
Any opposed? Any abstentions? Okay, so it's done. Thank you, Mr. Warden.